Sure, yeah.
All right, roll.
Can you guys see the screen?
Good.
Okay, so start off with a congenital case. This is a patient in her mid-30s. She was born with tricuspid atresia, hypoplastic right ventricle, and bicuspid aortic valve. And she's been repaired with a lateral tunnel Fontan. And now the main problem now that they're working on is this bicuspid valve is causing severe insufficiency, and they need to replace it. So this is kind of a preoperative scan. It's a good scan showing the lateral tunnel Fontan, and unfortunately we didn't pacify the Fontan very well to look for patency, but there was a recent cardiac MRI which showed it was patent. So you have just quick review, you have the IVC here, and as we come up, it goes into a baffle in the right atrium, and it shunts it away from the tricuspid valve, which is atretic. And as you go up more superiorly, you have the superior vena cava communicating with this, which is the right pulmonary artery. And you can see the very dilated left ventricle from the insufficiency. And then the incidental thing that I saw on this, which they didn't know about, was as I scrolled down and see this dilatation here of the RV apex, and so you also see these dilated vessels here. So this is actually if you track them, this is a fistula, cameral fistula between the obtuse marginal artery and the right ventricle.
Okay.
And it was probably congenital, but I think it's probably in a normal patient it wouldn't be a big deal because the blood is still returning to the right side. But in this case, I think it might be important because the whole one of the functions of this Fontan is to shunt to prevent blood from going into the hypoplastic RV. Whereas in this case, you have shunting it, and most likely there's high pressures here in you can see the coronary sinus, where you would expect where you're expecting the coronaries to be draining is very dilated, and you can see the coronary sinus is communicating with the left atrium, which probably has elevated pressures from the insufficiency. So that might have increased the shunting through this fistula here. And I'm not sure exactly if they're just going to replace they haven't replaced the valve only, or if they're going to actually repair the fistula as well separately. I'll show one other case.
Is there any particular association between a coronary RV connection and the other findings that are present, the other congenital?
I tried to look for it, if there's an association with no, I didn't specifically find one, but I'm not sure.
That's very curious, isn't it?
Yeah, she had several congenital abnormalities, so most likely they went together. The other case that I have is both a chest and an abdomen, and I'll show the abdomen. I should start off by showing the abdomen actually. So this is a 60-year-old patient, and they have a history of medullary thyroid cancer, and we've actually been imaging this patient for about 5 years. But the main finding here is this circumferential infiltrative soft tissue encasing the kidneys and the retroperitoneum of the kidneys and the aorta on the abdomen. If you go up into the chest, you do have some infiltrative soft tissue here in the chest wall. But we really like this for Erdheim-Chester, and they had actually biopsied this patient in 2015. They did a biopsy and got some of this. They went with the needle CT guided here and got some of this tissue here from the retroperitoneum. But I'm not sure. It basically was non-specific. Came back as non-specific fibrous tissue. But I don't think they did the immunohistochemical analysis to evaluate. So I'm not sure we tried. We don't really trust the biopsy. I still think this might be Erdheim-Chester. We don't have imaging, unfortunately, of the lower extremities to look at the bones. And these bones look look okay.
Is there any lungs or in the chest?
Yeah, I can show the chest.
Yeah. And I had a question about the aorta. It looked like there's some. I know there's some atherosclerosis, but did you guys think some of it might be aortitis and not just atheroma? You kind of showed a little bit on the abdomen.
Then so we looked back through multiple older studies, and with aortitis, you would expect. Unless it was chronically inflamed, you would expect some change, but it was kind of unchanged over many years.
Sclerosis. So not much lung involvement. It doesn't look like
not much lung involvement. You don't see it very well, but in several other studies, the heart is very hypertrophied everywhere, but the patient also has kidney failure, so they're hypertensive. So that's not really a
so
nice case.
Peter, is there a PET scan in this person?
There wasn't. So we didn't have a PET scan. They had several Ectria scans for his medullary thyroid.
Peter, there was a PET scan.
Oh, okay. I thought it was an Ectria scan.
No, there was a PET scan, and it actually showed mild uptake in that paraspinous soft tissue.
Okay.
How about the periaortic stuff, the perirenal stuff? Did the kidneys light up or not?
Yes.
Because I've seen cases where they don't light up, and that would correspond to a diagnosis of fibrosis, which is what Erdheim-Chester can lead to. So if it's a mature fibrosis, then it would be much less active on PET. Might even be, cold. But so
it certainly wasn't a light bulb. It was just mild uptake to my eye. But this has been an ongoing issue for years for this patient.
Very interesting.
All right. Thank you.
Thank you.
All right. Howard or David?
I could go. So here's a fellow who is getting short of breath, and this chest radiograph, as the symptoms were getting worse, shows a very fine stippling throughout the lungs here. And it's helpful to have comparison radiographs to show that it wasn't there a while ago. So please take my word for it at this point. And he had a CT scan around this time, and it does show that he's got these very small little lung nodules. Let me show you finer slices here to help bring this out. And you will agree, I think, that he has tiny little central lobular dots everywhere.
Yep.
And he has a diagnosis of pulmonary hypertension with right ventricular failure too, although his pulmonary artery is not particularly enlarged. He's got a little bit of lymphadenopathy here in his mediastinum and hyla and stuff like that. And he's got some consolidation in the right base. This could just be some atelectasis or aspiration going on in the bases. So he's very short of breath, and he died. And so coming from Seattle here and incorporating nice MIPS here, these little dots all seem to be incorporated into the vascular pattern here. So I don't really see any dots, central lobular dots, that are independent of the vessels, but the vessels seem to have these tiny little branches. It just looks like busy vessels here. So all the dots could be vascular. Normally with central lobular dots, you think first of airways and then vascular disease, especially around here, we think of excipient lung disease. So I made, based on the imaging here, I thought this was excipient lung disease. The guy does not take painkillers. He doesn't have an indwelling catheter and stuff like that. So he doesn't really have some of the social setup that we see for people to inject tablets, ground up tablets. And he died. And let me show you a path slide here. I think I've got one that's going to come up. So this is what he had. This is the cause of the little dots here. And this is courtesy of Dr. Marshall, our autopsy pathologist who presented this case earlier this week. So we have all of these little intravascular things here. So we have these microscopic intravascular thrombi. This was not thromboembolic disease. This is in situ thrombosis. And there is some angiopathy, some inflammation, I guess, and thickening of the arterial wall around these little central lobular thingies here. And they looked carefully. They found that there were actually some atypical cells mixed in with this. And so the path diagnosis actually took a second glance because the number of atypical cells, some of which were signet ring cells, was pretty sparse initially. There was the thrombotic material, but it turns out that this was actually tumor-induced in situ thrombosis. And so this is a case of PTTM, which stands for pulmonary tumor thrombotic microangiopathy. And on sort of going through the organs again, they found a small carcinoma with signet ring characteristics at the gastroesophageal junction, and there were some positive lymph nodes around that. The mediastinal lymph nodes were not sampled, were not looked at microscopically, but the hilar lymph nodes were. They found that there were some metastatic cells in vessels in those lymph nodes, but the cause of the lymphadenopathy was not gross tumor. So this is in the differential now for me of excipient lung disease with central lobular vascular dots. And this is pulmonary tumor thrombotic microangiopathy, a spectacular case.
Wow.
So this fellow didn't really have a chance. And this disease, his CT scans had been getting worse over a period of a few weeks. He had about a 5-pound weight loss over some time. It was not a intentional weight loss. So I've seen one previous case of this, I think. It was years ago, and it was very small central lobular metastases. And I don't recall whether that person also had a thrombotic component, but the malignant cells were causing this localized thrombosis. Is that cool? Have you guys encountered this?
We had one case here many, many years ago. I don't remember what the primary was, but same thing, sort of presented a rapid declining shortness of breath, elevated right heart pressures, and I think they made the diagnosis on I want to say a bronch biopsy.
Yeah.
They took a chunk and got some blood vessels in there, but I don't remember that case being as exuberant, the extent of small nodules, but I like your MIPS because it really shows the distribution.
Yeah. That's remarkable. This is very unusual, but I usually think about it, and I usually make that diagnosis once like a decade maybe, in a patient that has cancer, that has developed pulmonary hypertension, which is new or worsening.
Right.
And if the CT on lung window shows a pattern of mosaic attenuation, even if there are no nodules in the lungs and no hint of a parenchymal abnormality. So in going back here, can we look at the lungs again and see if we perceive any hint of mosaic attenuation? Because the distribution of these lesions is often not uniform in the lungs, and it might be hard to tell, of course. But no, it's remarkable. I've never seen a case of actual central lobular nodules. I think if we look at that, one can perceive, because now we're biased, that there may be a mild mosaic attenuation pattern. It's not uniform.
Good, yeah.
I've never seen a case where we almost see, well, of course, these central lobular lesions. But I think if we look behind them, maybe we can perceive a mosaic attenuation appearance. But
I
of course,
agree.
really subtle.
And it's a lobular level, so it's the same sort of airways pattern, you know, of small bronchiolar lesions that cause a lobular air trapping or mosaicism. This is lobular, but it's on the basis of a vascular disease. So yes, that's a good observation. So the remarkable thing here is that just a small number of tumor cells can induce thrombi, and the lesions that we're seeing here are mostly these microthrombi. They're not, it's not really tumor cells that we're seeing causing these visible dots. These macroscopic dots that we can see on CT are the thrombus induced by a small number of cancer cells. Okay.
Well, I've heard of this before, but I've never seen a case until today of the findings that you're showing, actually seen a case of it like this.
Well, our
That's from-
pathologist, Dr. Desiree Marshall, was also very impressed by this case. She said it was her best case ever. So I thought it was, we just presented excipient lung disease case last month. So I thought she's not going to do two in a row. It wouldn't be that exciting to be her best case ever when we just had a similar excipient lung case the month before. So I was very attuned, and these remarkable findings emerged.
Absolutely remarkable. Terrible for the patient, of course, but yeah, that's dramatic.
So here's a person with an asymmetric pattern of septal lines. So we have lots of septal lines here on the right. We have accompanying pleural effusion. And we have relatively few on the left. So it's really way asymmetric. So I was looking at this radiograph and said, it would be very unusual for edema to be the cause of such asymmetric pattern here. I thought, you know, could this be mitral regurg with a jet directed to the right? But that's usually more localized in mid and upper lung and not really so diffuse here. So CT confirms that the interstitium is abnormal. Here there are tons of septal lines, and there are some on the other side, but not as many. Lots of fat, juicy septal lines, accompanying pleural effusion on both sides. We get down into the abdomen, and there's some ascites. There's a big heart. There's a nodular component. Maybe in the lung bases here, this gets probably beyond septa. And there's one little, calcification down here. Okay, so this person had a lung biopsy. This person also has acute on chronic intermittent heart failure, and the lung biopsy returned AL amyloidosis. It was a positive Congo red stain of the lung tissue. And it's presumed that the heart disease is probably also amyloid in this person. This person does have a monoclonal gammopathy as well. So this is amyloid. I think last week, I think Peter presented some cases of amyloid. And this is a really nice example of the septal pattern of amyloidosis. And then maybe there are some nodular lesions in the bases here, but it's really hard to tell. There's so much atelectasis. I don't know really whether these really qualify as nodules. And then if this calcification is part of this one process and it's not, say, a separate thing like a granuloma, then that could be a little bit of bone that is developing in the setting of amyloid. So cause of dendriform pulmonary ossification, or sometimes larger blobs of bone. Okay, so amyloid, definitely in the lung and probably in the heart too.
Yeah.
Okay, and then this is a person who'd had a heart transplant and does have a diaphragm complication of heart transplant. The hemidiaphragm is elevated here. The on CT, the crus is thinner than it was pre-op, but it's not completely wiped out the way it would be with paralysis. So I think there's still some phrenic nerve function going on, and the diaphragm hasn't atrophied to the point that it would, but it's been elevated now for several months. She had two surgeries. Initially, she had an LVAD, and then she went to transplant. Or she might have had an artificial heart going to transplant. She had two procedures on the way. And then she has perhaps some very low grade little fuzzy nodular consolidations here. She got a CT scan, and lo and behold, she's got a ton of nodules. So lots of nodules, and they have a mid-lung and basal predominance. So they're not the upper lung distribution or mid-upper that we see with Aspergillus. She's got a big blob down here, which is probably just atelectasis associated with her elevated right hemidiaphragm, because this has been there pretty stable for months, but the nodules are new. So when I see nodules of this number, and they're pretty well defined and stuff like that, it's not a very good pattern for Aspergillus. Usually you don't see this many lesions with Aspergillus, and the nodules are more ragged looking than these. So you start to put, I would put PTLD ahead of that, because the lesion, you can have numerous lesions with that. And she did have EBV status that would promote, you know, her susceptibility to PTLD. The other thing that can have lots of nodules is nocardia. And this turns out to be nocardia nova. So last week, Jeff showed a case of very smooth lesion, a single lesion in the right lower lobe that was a nocardia species. And this is also nocardia. So it's not a very good pattern for Aspergillus. So I had PTLD in mind. And I also allowed the possibility of nocardia. So nocardia is what it turned out to be.
Very nice.
Yeah.
Okay.
So I found my case of the same thing that you showed, David, if you don't mind me showing it, Howard.
Yeah.
So this was a young female who presented very similarly with shortness of breath and had a breast cancer history. And she was admitted to the ICU, and actually the pulmonologist caring for her was a pulmonary hypertension person. But you can see she has this mosaic attenuation, and the nodules are very smudgy. This was an outside scan, so it was thicker cuts than we do here, but you can see the patchy ground glass and just the heterogeneity of it. But almost you get the sense some are central lobular, but you don't have those well-defined tree and bud. And this almost looks like a little organizing pneumonia. But she had severe pulmonary hypertension. You can see her right heart is really dilated, and there's some, some. And this was acute. So I think she had a previously normal echo when she was getting her first chemotherapy. So yeah, and it was on. I can't remember if it was a biopsy or an autopsy. I think it was a biopsy. They found tumor. She's got, looks like maybe some tumor down there, but this was from that. So as Howard was mentioning, it's the mosaic attenuation pattern.
Yeah. Wow.
Yeah. But she had a known malignancy. You can see she's been treated for breast cancer up there. So. But yeah, it was rapidly progressive. Let's see, I actually have a report here. Let's see what I have. Oh, here, I will, there you can see that. So, yeah, right heart cath. Oh, I remember, let's see. So then, I remember now. Yeah, they actually sampled, when they did the right heart cath, they actually took some blood out, and you can see it had positive cytology.
Gosh, yeah.
Yeah. So she died after 3 days, and she just had very low pressure. She required vasotherapy, vasopressors, and then they weren't able to give her a vasodilator.
But no autopsy.
No, but they had it in the pulmonary arterial blood.
Mm-hmm.
So that's another way you can make this diagnosis. Yeah, it's been a while since I remember this case, but yeah, they can when they do the right heart cath, they can actually take a sample, and that's how they establish the diagnosis. But I don't know how much of this was angiopathy, how much was in situ thrombus, micrometastases, but clearly rapidly progressive shortness of breath, acute onset cor pulmonale in the right.
Yes. Yeah.
Okay. I have 2 other cases, and I'll turn it over to you, Howard. We have plenty of time.
Oh, sure. Oh, sure.
This is kind of something interesting. So this is a 46-year-old. I got to get the right case. Yeah, that's the one, who had a pulmonary AVM, does not have HHT, but has this really large pulmonary AVM. Looks like it has a single feeding artery and single draining vein. So this one actually looks like a lung nodule, except of course it's contrasted, and so wouldn't want to biopsy it. So this was treated elsewhere with embolization, and they did Amplatz or plugging. I'll show you. Let me move this out of the way and show you what they did. So they put in one of these plugs right here.
Yeah.
And you can see it looks like so to obstruct it, and it mostly did its job, but you can see there was still having some symptoms, and the shunt fraction wasn't back to baseline or where it should be. There's a little bit of contrast coming in here, and I think it's coming from this little branch right there into the AVM. So it's almost like an endo leak equivalent, where it's just leaking around the plug. But I've not seen one of these plugs used before. I mean, I've seen, at least for AVMs, usually they coil them. So, but this is what they used. And at the time of the procedure, there was no residual flow. So over time, there must have developed this endo leak. And so to treat this, you'd probably have to go upstream and probably drop some coils, but make sure that there's not any side feeders coming in there as well, because you'd see that draining vein is still pacifying and going back. So that's just interesting. It's an interesting treatment. It's a weird looking AVM, and it's a complication. I've seen them recanalize or have other channels, but I don't think I've seen one leak around a plug. So I thought that was kind of neat. And then this is just a really nice example of a patient who has ulcerative colitis, is on sulfasalazine, and developed some respiratory symptoms. And one of the prettier examples I've seen of migratory organizing pneumonia. So you got nice atoll halos. I don't think there's any question of what the diagnosis is. Hopefully I'm showing these in the right order. But, you know, the question always is it coming from the, so that was a presentation, this is 2 months later. Is it coming from the ulcerative colitis, or is it coming from the drug? My guess it's probably the drug, because sulfasalazine is known for causing organizing pneumonia. But you can see that this is not that somehow. I had a problem with it. I haven't posted my cases. I've had problem with cases merging. I did something wrong there, so I'm not sure why that happened. But I do want to show this case. So this is actually 2 cases in one. So that was organizing pneumonia. But what I wanted to show in this case was a neat congenital thing here. So this patient has what looks like a unicuspid valve, or an abnormal valve, has a dilated ascending aorta, but you'll notice the origin of the left coronary artery, and I'll make a coronal, comes off quite high. It's above the cusp. So it looks like it's coming from the tubular portion. And then to follow the rule of congenital, there's a nice funny looking vein here in the right upper lobe. You can see this funny vein. So this is a meandering pulmonary vein that comes way down. And what's cool about it is it comes into what looks like a common antrum to all the pulmonary veins on the right, just like, you know, we often see on the left, and this patient has it on the left. The 2 pulmonary veins come into this common antrum and then communicates with the left atrium. All the right pulmonary veins come into this little compartment here, the inferior, the middle lobe, and this meandering vein coming from up top. And there's also a superior vein coming in, and they all kind of drop in here. So multiple congenital anomalies. I'll do the coronal to show you that ascending aorta. But you can see that there's the high origin of the left coronary just above the sinuses of Valsalva there, with what I think is a unicuspid valve. I don't think I put it in all 3 planes, but yeah, I'll get these cleaned up and then send you that. But it is a nice case of organizing pneumonia, just pretty atolls, but they moved around. That was the finding. All right, Howard, let me get this control to you.
Okay, let me start with this one. I'm going to not give you any information starting off, but I'm going to scroll through this. Let me see. Okay, so clearly we have a contrast in NCT, and this person is a smoker, so there's emphysema. But beyond that, as I scroll through that, look at the lungs in general. So I'll scroll through there relatively slowly. And at this point, there's no mystery about the bully, but look at the lungs in general. And if I hesitate at one point, then I'm passing a lesion that I find particularly interesting. But I'm just going to scroll through there and give you a moment to make observations and decide how you would report a case like this. Look at this. That. I'm only pointing out a few selected interesting things in the lungs that are very, very abnormal. So, having scrolled through there relatively slowly, any comments?
So it looks like each individual one you showed looks like, some of them look like typical, part solid, part cystic lesions that are classic for adenocarcinomas. And I think you're showing a nice example of sort of multifocal, separate primaries, sort of the field effect. And I'm sure you've all seen these in your tumor boards where you have to, they treat one and then you have to decide what to do with all the other ones and when to act. But I've never seen one with this many separate ones. This has got to be, I don't know, 30, 40.
This, if you look and you scroll through a case like this, you can start to imagine that you're seeing maybe not even dozens, but much more than that.
Yeah.
Where there are so many focal ground glass attenuating lesions throughout the lungs, every lobe, every place, in addition to these interesting lesions that we call pseudocavitation, and in addition to these larger solid lesions here and there. So that's exactly the case. So that's in 2017. It's been a dilemma for a while. I will show you that in terms of what happened over time was that lesions 1 in the right lower lobe increased in size, which is this one. An initial needle biopsy of that showed atypical cells. The patient did go to surgery, and that is a adenocarcinoma. Let me bring up the report here, because the report issued by the pathologist is really interesting to look at as well. So here you see the adenocarcinoma, and you can see the description by the pathologist of incidental, separate, multifocal adenocarcinoma, at least 4. And you can see the same comment here for another lesion. And that, given what we see in the CT, is not surprising at all. And that's exactly the case. So Jeff mentioned that you can find articles like this titled Field Cancerization in Non-Small Cell Lung Cancer. And this is something that's just known to happen, and it's a terrible dilemma in terms of patient management. And one of the questions about this too has to do with whether, sometimes if you have a small cancer and you see a cancer in another place and you diagnose that, is one erogenous spread? Do you have separate synchronous tumors? And in recent years, they've actually started to do some genetic analysis to try to look at the clonality of these multifocal. And at least in some patients, as you can see here from the abstract, that there is evidence from these other cell surface receptors that some of these are all separate clonal tumors. They're just separate tumors, at least in some proportion of patients, that are growing in the person's lungs. So certainly the notion of the field cancerization phenomenon and the clonality of tumors. And this is the most dramatic one I've seen, I think, in quite a while. So as Jeff intimated, typically there's nothing you can do except to follow those and just manage accordingly when something gets bigger. I just want to remind myself to see whether actually there was a metastasis. So even though this isn't big, right there, this unfortunate patient does have metastatic adenocarcinoma in the level 9 lymph node. as well. All right, here is an interesting teaching case. Nothing super dramatic, but just a nice combination of imaging findings. So there are three big findings: right middle lobe opacity and volume loss, collapse, nodules in both lungs, and in looking at the hilar regions, enlarged lymph nodes. So three things. When we look at the CT, as you already expect, we'll see nodules, the typical appearance and distribution of sarcoidosis. In looking at the lymph nodes, we see the same finding, big nodes. Some have the amorphous calcium, which one sees pretty typically with sarcoidosis. So what's really interesting in this patient is not so much that, but the right middle lobe atelectasis. So if we look at that, we can see that, yes, we have air in medial segment. Not much beyond that. There's the origin, but otherwise a pretty atelectatic lung lobe. So this is somewhat interesting because the pathologist, I'll just go to the report if I get that up. She was interested because she made the comment about the fact that there are lots of non-necrotizing granulomas, but impinging on and involving the submucosa of the airways, which is somewhat unusual for sarcoidosis because they usually stay within the bronchovascular sheath in a perilymphatic distribution. But apparently that has been reported. So that may be playing a role, but we actually have images from the bronchoscopy that shows it's more than just that, because here is a big bulge into the lumen of the bronchus, I think undoubtedly from an enlarged lymph node. So there is volume loss, but probably mostly due to this thing, which is extrinsic impression from an enlarged lymph node or lymph nodes adjacent to the origin of that right middle lobe bronchus. So a nice case, unusual to have a lobar atelectasis, but when we see the pathology, that makes sense. I didn't know about this other thing. I'll still have to go and maybe take a look at that article to see what the pathologist is talking about and so on. So that's interesting. All right, the last patient I'm going to show presented, I can't remember if she presented at another hospital with a pneumothorax. A chest tube is now present, a catheter. So the lung is up. There is a very small amount of residual pleural air in the pleural space. So far we have a young person with an apparent primary spontaneous pneumothorax with expansion of the lung. But if you look at the lungs now and look at the vessels, they are simply not normal. They appear to be small. In some areas up here, they appear to be particularly small. These vessels here again are not normal. Some appear to be quite attenuated. And it's the kind of case where the more you look, the more the vessels seem abnormal in terms of their caliber, their branching perhaps pattern, and seem to be asymmetric, perhaps left versus right. So something's wrong. So here is the CT. I'll scroll through that. And of course, we'll see the abnormal vessels, the attenuated vessels, the asymmetry of attenuation of the vessels, the areas of lung right here that really seem to be devoid of vessels. One should start to think, is it a primary vascular disease? Is it also potentially an obliterative bronchial disease with areas of air trapping? How much is vascular and how much is airway-related disease? So it turns out that by history, this person was a premature baby, and she was told that she had bronchopulmonary dysplasia or chronic lung disease of prematurity. And I think the imaging findings here as an adult are very consistent with that. And I don't know the exact relationship between this and the pneumothorax, but I suppose the lungs are abnormal and maybe potentially at some risk for a pneumothorax if you have obstructive bronchial disease, hyperinflation, and so on. Does anyone doubt that that's what it is? I think that I'm quite happy with that as an explanation.
Can you go back to the top? Does she have any subpleural bullae? This
Yeah.
doesn't look like it. No, not really.
Oh, she's got apical bullae though. A coronal would be cool.
Let's take a look at, I don't think I have from the outside thin cuts. Let me have a look. I don't think I have thins.
I think those little bubbles at the apex are all it takes to pop.
Maybe in combination with
the
other findings.
Yeah.
Perhaps.
Yeah, all of the cases of BPD that I have seen look like Swire-James syndrome to me. I mean, that's the first thing I would land on, is some sort of constrictive bronchiolitis. So this fits that, the cases that I've seen, the few cases I've seen of BPD in adults.
Yeah. Yeah, I think so too.
I mean, I wonder what the histology is, whether this is constrictive bronchiolitis under the microscope.
Yeah, I don't know. One would think the airways are probably abnormal, because these areas of lung are so abnormal. They seem to be hyperinflated. They've got vessels in. They don't have discrete cysts in.
Howard, did you guys have PFTs?
I don't think so. No, not that I know of. In terms of sort of trying to establish maybe the severity of obstructive airways disease in general.
And nothing in the way of expiratory imaging either, right?
No. No, these are from the outside. That's all we have. Yeah.
That's a nice example. It's interesting though. It looks like there's some volume loss in the lower lobes too, and it may just be that the upper lobes are hyperinflated. If you look on the axials, the fissures are retracted quite a bit.
Yeah.
They may be underdeveloped too. They could just be small.
Yeah, it could be a combination of simple underdevelopment of lung tissue.
Which is also a small process. She probably has pleural effusion, pleural thickening from her recent pneumothorax and tube.
Yeah.
All right. Well,
very good. Those are my cases.
Thanks. All right. Well, we'll finish a little early today, but good stuff.
Thanks, everyone.
Talk to everybody next week.
Bye-bye.
Thanks, David. Thanks, everyone. Thanks, Peter.